So if everybody could come on camera, that would be great. Okay, I think we're missing 2 or 3 students. How's everybody doing for a Tuesday of week 5?
Not bad. How are you?
I'm doing okay. Thanks for asking. It's hard to believe it's week 5, isn't it? Really hard to believe
Yes.
it's week 5. Does anybody have any questions before I go through a few things? So today we'll do quiz 3 at the beginning of class, and then we'll go through quiz 3, do some teaching for the concepts. There are a lot of concepts to cover between weeks 4 and 5. And then actually that took me most of the class yesterday after we did the quiz to cover all these concepts from the information that wasn't on the quiz. So we'll do that. In your recent announcements, well, going back to week 4, you had your concept recording for week 4. Are those helping, the concept recordings? Are those helping in preparing for the quizzes and having an introduction to the content, the concepts that are being covered? Do you like the concept recordings? Because those are new this term, so I'd like your feedback.
Hello, Professor. I found the week 5 recording, not for week 4.
Pardon me?
I couldn't, for the concept recording, I only get week 5, not week 4.
Yeah,
But
week 4, there was a concept. There's been a concept recording in each week. They're
yeah, I didn't
attached.
find it.
They're attached to the bottom of the announcement. Have others seen week 4? Yes?
Yeah.
No? Yeah, they're there, Barbara. Okay. So also in your week 4 announcement, obviously we didn't cover week 4 last week because it was an exam. I also sent the study guide for exam 2 that covers concepts for weeks 4, 5, and 6. That was in your week 4 announcement. So today we'll cover weeks 4 and 5, and then next week we'll cover week 6. Remember that next week are exam 2 reviews. So have a look at your master schedule and see if you can attend any of them. I believe they're Wednesday, Friday, and Sunday. So have a look. You also have your group assignments. Has everybody at least reached out to your group to talk about what you're going to be doing, who's going to be doing what, I hope? Okay. If you haven't, somebody in your group needs to take the lead and send out an email that for your group, sorting out which parts of the research paper everybody wants to do. So I know it's only week 5, it's not due till the end of week 7, but probably a good idea to start working on that. Okay. I didn't have it ready when I sent out your week 5 announcement over the weekend, but I did send you an additional announcement that has a Kahoot activity that is a review for weeks 4 and 5. So I would encourage you to have a look at that Kahoot activity. It's just an additional resource for you to practice with exam for weeks 4 and 5 content.
And then that's only 10 questions, correct?
Was it only 10 questions?
Yes.
Has anybody done
Yeah.
the Kahoot yet?
Yeah, it was only 10 questions for
Okay.
week 4 and 5. It was a little light.
Yeah,
Was
it's very-
it?
Yeah.
Okay. Okay. Professor Kershaw does our Kahoots, so maybe I will ask her to, was it covered mostly 4 and 5 or both?
I believe just 4, but I think
I'll
it was
have a
one
look.
It was 4 and
125.
5, but it wasn't many questions.
Yeah.
Okay. And then the last bit of information is exam one. So exam one grades were posted late Friday night. I have heard from some students, not everybody I need to hear from. If you scored below a 78 and you haven't been in contact with me, you need to be, okay? We need to schedule a tutoring session to review the concepts missed or struggled with for exam one. Okay, there's a lot of students I still haven't heard from. All right, and that's kind of mandatory. If you get below a 78, we really do need to have a look at the exam and see, is it knowledge? Is it the way you're reading questions, attacking questions? So if you haven't contacted me yet, please do to schedule a session. Give me some days and times this week that will work. If you scored above a 78, congratulations. I am also still available to meet with you to review any of the concepts that you might have struggled with. So I'm available actually to meet with anybody. Okay, but I really would like to prioritize meeting with the students that score below a 78. All righty. Any questions? Those are kind of my housekeeping items for the beginning. Okay, so if you tried to pull up your quiz before class started, you're going to need to refresh because it wasn't available till 1 o'clock. All right, now it's 1:07. So the code to get in the quiz, I'm going to put in the chat. It's my last name. So let's everybody go on mute, including me. We'll take 15 minutes to do the quiz. So it's 1:08. So 10, 25. So we'll come back around 1:25. If you finish early, you can go off camera. That's fine, but you need to be on camera while you take the quiz. And please submit it before you go off camera. Okay, so go ahead and get started on the quiz. I'm going to mute myself and then we'll be back in about 15, 17 minutes and we'll review it and then go over all the concepts for the last 2 weeks. Sound good? Okay. If you have any questions during the quiz, please put them in the chat. Okay, it looks like everybody's done. If you'd like to start coming back on camera, please. How'd you do? Everybody's quiet today. Okay. Need to, everybody come back on camera, please. Okay. Okay. Let me share my screen and we can take a look at the quiz. Can everybody see my screen?
Yes.
Yes,
Yeah.
everybody can see it?
Yes.
Okay, PTSD. The nurse is assessing a client with PTSD. Which of the following would be expected finding? Are the rationales in the quiz helping you? As you read through them, whether you got the answer correct or not, are the rationales helping?
Yes.
Okay.
Mhm, yes.
Did you all use your do you use your rationales in the quizzes as you're reviewing for the exams?
Mm-hmm.
And is that helpful?
Yes, ma'am.
Yeah, yeah. Because in a lot of these questions, we're introducing the concept we're covering, right? So obviously this question came from the mental health section, the mental health readings. All right, so what did we learn about PTSD? If you look at the rationale, right, it's characterized by a previous event that involved threatening death, serious injury to self or others, in which the individual experienced intense fear, helplessness, or horror. Right? And the remembrance of such events produces feelings of intense distress along with anxiety, maybe nightmares, flashbacks, in which the event is somehow relived or that it's recurrent. Okay, so that's a pretty good definition of PTSD. When we go back and cover the rest of our concepts, we'll also talk about generalized anxiety disorder, phobias, OCD. PTSD is one of them, suicidal ideation. So we'll also cover those.
I have a real quick question. I'm so sorry.
Yeah.
So for the rest of the term, we're going to go over the quizzes every time because I feel like it's a waste of time, not to be rude, because we have the quizzes already. I want to go over content. I'm very confused about palliative care versus hospice. I don't understand the difference. I even tried to YouTube it, and we're going over the quiz and we have it already.
Okay. I appreciate that feedback. What I try to do in covering the quizzes is cover the content from each of the concepts that are introduced. Later on in the lecture, we'll get to hospice and palliative care. All right, so these quizzes are introducing the concepts. So I feel like it's helpful. This is the way I conduct the lecture. I don't spend a lot of time on the quizzes, but we do introduce a lot of the information we're covering. So maybe Jeanette, you and I, maybe stay on after and we'll set up a time. How's that? Will that work?
Yeah, I would love that.
Okay, so stay on after and we'll set up a time. Okay, this question comes from the concept of the alcohol, tobacco, and other drug use. Okay, so the importance here is what's applied to determining the blood alcohol concentration. If you look at the rationale, a lot of students get confused about how you determine a blood alcohol level. A lot of students or a lot of people think it's just really the amount that you drink, right? But if you look down here in the last part of this rationale, okay, it's determined by several things, by the concentration, by the rate of drinking, the rate of absorption, when you last ate, the rate of metabolism, person's weight, person's sex. So that's the takeaway from here. Okay. We do know that alcohol costs billions and billions of dollars in lost productivity, property damage, medical expenses from alcohol-related illnesses, causes accidents, family disruptions, alcohol-related violence, and maybe even neglect, child abuse. Okay, we know that chronic alcohol abuse has multiple metabolic and physiological effects on all your organs. Okay. So that's an introduction to the one of the parts of the alcohol, tobacco, and other drugs. Another mental health question. LPN prepares to care for a client with anxiety. What might you observe? What did you learn about when reading the chapter about mental disorders? Did you guys get this one correct as far as what you might observe with regards to anxiety? Okay, we know that anxiety is expected. Okay, every one of us experience anxiety. It's a common emotion. All right, it's considered normal, healthy, unless it becomes so debilitating that it impairs your ability to function, right, in your everyday life activities. Okay. The next question, one of our concepts were pregnant adolescents. Okay. And through your readings, you should have determined that when the nurse is working with pregnant teens, what is the most important long-term goal that we should be focused on? What are one of the big issues with adolescent teens?
Dropping out of school.
Dropping out of school,
Education.
right? Dropping out of school. So the correct answer was identifying or developing programs that will allow the teen mothers to complete their education. We'll talk about that in more depth in just a little bit. All right, but we do know that a direct correlation exists between poverty and poor health outcomes with this population. We know that poor teens are nearly 3 times more likely to drop out of school than their non-poor counterparts. And so we know that when programs are available, resources are available to assist the mother in completing her education, that's always positive. The chances of an increased having a better future for both her and the child improves over the long term. That's a key takeaway. It's one of the biggest risks for adolescent teens. Talk about more about that a little bit later. Another very vulnerable population that was covered in week 4 is the LGBTQ population. Okay, so culturally competent nurse leads an in-service on nurses, for nurses and how to care for this population. Which statement conveys the most accurate information about LGBTQ? In your readings from week 4, you had some module readings. Okay, those are the readings that are embedded into your weekly module. And this question came from that reading. All right, so when you're talking about the acronym reflects both gender identity and sexual orientation identities. It's both. Okay, and I want to go through this rationale because this is basically the teaching on LGBTQ population, how we care for them. Okay, first of all, I have a question. What does it mean to provide culturally competent care? What does it mean? I don't typically call on students, but I also don't expect 28 students to be quiet either. So what's culturally competent care?
I'm sorry. I think
That's
that
okay.
we need to have a better understanding of our own culture without biases.
Yep. Okay.
Mhm.
That's part of it. But how do we know we're providing culturally competent care? I mean, all of us in our workplaces,
Uh,
in
maybe
our
by approaching,
communities, work
sorry.
with different cultures, whether it's teachers, kids' friends, parents, workplace. We all work with different cultures. What does it mean to provide culturally competent care?
It's being respectful to everyone because you know, like certain people can have certain cultures can have different uh ways of doing things. And just
Absolutely.
being respectful.
Basically, go ahead. Basically
Pardon
just
me?
treating everyone equally.
Right? Providing culturally competent care means that we are aware of different cultures and their attitudes, their beliefs, their practices. And we always try and incorporate as much of their practices into their health plan, right? Somebody just put a message in the chat. I can't see it from here. I'll have to stop and share to see that message. Okay. Okay, Chanel, I got your message. Okay, so culturally competent care is being aware of other cultures and how they expect to be treated. Right? One of the things that's first and foremost when working with different cultures or different vulnerable populations is being aware of our own feelings. Somebody already mentioned that, I think Barbara. Being aware of our own feelings about different populations. Okay. Do we have any stereotypes? Do we have any prejudices? Do we have any biases that we need to work through? Because you're not going to be able to provide culturally competent care unless you are aware of your own feelings. So let's look at this rationale. Nurses have an obligation to provide culturally competent care to LGBT families, and that goes along with all other vulnerable populations as well. Some nurses may feel a degree of discomfort discussing sexual orientation with their clients. However, it's important to overcome this barrier to care for LGBT families. The nurse should provide safe environment for clients to discuss their sexual orientation after understanding our own feelings when providing care to this population. It's important for the nurse to investigate if we're caring for this population. We should also be investigating what the same-sex marriage laws and family structures are within the state that you're working in, right? The impact of stereotyping and discrimination is evident through the lifespan of persons who are LGBTQ. You know, there's still, you know, we're doing a lot better in caring for this population, but there's still stereotyping, biases, discrimination. With regards to this population, we need to be very sensitive to that. Right? Although social acceptance of the LGBT people has been improving, they're still facing stigma and discrimination. Right? So sometimes these negative experiences that this population may have, combined with lack of access to culturally affirming and informed healthcare, result in disparities, result in that discrimination, result in that stereotyping, result in the biases, right? So ultimately, there's an urgent need to provide inclusive, high quality health services to this population so they can achieve like everybody else, the highest possible level of health. Does that make sense?
Yes.
Okay. We covered most of this in our last rationale, but which of the following should be the initial consideration made by the nurse working with LGBT families and homeless and pregnant adolescents? Right? We just reviewed this. The answer is B, understanding our personal feelings. You know, with anyone that we're providing care to. So yes, understanding our own feelings during the working with the LGBT, we have to extend that out, right, to other special vulnerable populations. What about people with mental illnesses? What about people with substance abuse issues? What about the homeless population? What about the families who live in poverty or individuals that live in poverty? All right, what about the pregnant adolescents? Right? We have to have an understanding of our own feelings so that we can provide culturally competent care. Okay, which intervention isn't appropriate for caring for the client undergoing alcohol withdrawal? So this is one of those negatively framed questions that you'll see on quizzes and exams. You have to be able to pull out that word isn't. Okay, so we're kind of looking for the wrong answer here. Which isn't appropriate? Oh, I'm sorry.
I'm sorry. I put address hallucinations therapeutically because I thought like if they are, because the rationale on there, it says during alcohol withdrawal, clients may express delirium. So, why would they eat or drink if they are going through this? Because like almost everyone that I've seen go through alcohol withdrawal, they cannot eat or drink. They are NPO. So why would it be the one that isn't appropriate is to, I thought address hallucinations because you can't address anything therapeutically if they're going through alcohol withdrawal.
Well, actually, that's not completely true. During alcohol withdrawal, they may be having hallucinations, correct?
Right.
So we have to address that. During alcohol withdrawal, we are monitoring their vital signs.
So,
We are trying to,
right. Go ahead. Go ahead.
no, go ahead.
Well, it's just that I don't know. I just felt like, the safe way would maintain NPO status until they can swallow again, because it says also right here to provide seizure precautions. Why would you give someone water if they have seizure precautions? Like if they are out of it, like, cause normally people that are going through alcohol withdrawal,
Mhm.
they are not with it. They're not with it.
Well, we
Usually.
certainly want to keep them hydrated, which is
Right.
why the rationale includes ensuring that IV access has been
Right.
established.
Yes. So why the one that isn't appropriate, why would it
Oh.
be?
So maintain
Well,
NPOs.
why wouldn't it be appropriate to address hallucination therapeutically? Why wouldn't that be appropriate? It's appropriate.
It is appropriate. Right? The question is asking what isn't appropriate. We
That's
don't,
what,
right?
okay.
So we don't want to maintain NPO status. We want to keep them hydrated.
But
Right?
with an IV, correct? Normally when they come in the ER, they get a bag of like everyone that I've seen, they usually are NPO, like because they start hallucinating. And then whenever they hallucinate, we're just say, hey, reorient them to, hey, you're here, everything's okay.
But we also want to try and keep them hydrated. If they're not hallucinating and they're able to drink fluids, why wouldn't we be able to give them fluids?
Yeah, but that's just what I'm thinking is then it would say that. You know what I mean? If they're not hallucinating, what would be the appropriate care for undergoing alcohol withdrawal if they aren't hallucinating? Because like you can't address something if they're like not even with it, because sometimes they're in restraints. Like you
Mhm.
can't, You know what I mean? Like, so.
Well,
I just feel like-
overall, right? We
Because you're
don't want to,
maintaining airway and breathing. Maintain, that is the first step, is A, B, and C, airway,
Mhm.
breathing, circulation. So the first thing I
Right.
would be thinking of is aspiration in their airway. So that would,
Mhm.
I would put them in PO. And so I could see if they are capable of swallowing.
well, you're adding a lot of information into the question that
Cause it's
may,
only, that's only
So-
if they're hallucinating though, not all alcoholics
exactly.
hallucinate. It's not like a major common thing for alcoholics to hallucinate during withdrawal.
Well,
it
and
is.
it's,
Yeah.
It's
like
just
what-
if it
like what-
was hallucination, if it was not just not seeing, it's just if it was hallucination. You
Yeah, I
probably know,
worked in
I
a-
get what you're
I-
saying.
I
You're
worked-
thinking too deep into it. I feel like you thinking too
Yeah.
deep into it. What you're thinking is
Exactly.
right. If they are hallucinating, yeah, you're right. Everything you're saying is right. But this question is not saying that all alcoholics hallucinate. It's just
Oh,
saying
yeah,
what
you're right.
is an
That makes
appropriate.
sense.
Yeah.
Oh, okay. I
yeah,
see what
Yeah.
I think you're adding too much into the
Yes,
question.
you're
You're
right. You're
reading
right.
too much into it.
Yep, you're right. You're right. I didn't think of it that way. You're right. Thank you for explaining it. I appreciate it.
No problem.
Okay. Question number 8. Nurse is assessing a client with a binge eating disorder. The nurse understands which other comorbidities are commonly found with this disorder. So when reading about binge disorders, we know that there can be a family history and that a lot of times this disorder is also associated with some mental health comorbidities like depression. So let's look at the rationale. People with binge eating disorders may also have mental health problems such as depression, anxiety, suicidal thoughts, and may have a family history of the condition, right? These individuals may also have sleep disorders, right? They may also have problems with their digestive system because of their eating disorder, maybe joint or muscle pain. Okay, which of the following signs and symptoms of alcohol abuse intoxication would the nurse expect to see? Okay, well, we certainly know that C and D are just the opposite. It would be an unsteady gait and decreased alertness, correct? And then we know we would potentially see some drowsiness and slurred speech. Okay, we know that some of the signs and symptoms of alcohol intoxication involve several things. They involve consciousness, potentially cognition, perception, judgment, affect, and behavior. All right, it depends on the severity of the intoxication. Okay. Then the last question is a week 5 concept. All right, this is hospice care. So the nurse is caring for a client with a terminal disorder who is close to death. In reviewing the plan of care, the nurse determines which action is a priority. Okay, well, when we're caring for hospice clients, one of the priorities is to maintain the client's dignity and try to ensure as pain-free as possible. Let's look at the rationale here, and then we'll go back and cover that in more detail after we finish the quiz. So, nurse needs to focus on the needs of the client, keep the client comfortable, maintain dignity and self-esteem. Although we need to control pain, it's not necessary to keep the client so sedated that the client is unaware of what's happening. Right? The client should be able to interact with family members and make care decisions. That's that ethical principle of autonomy. Autonomy means we want the client to continue to participate in decision making as long as they can. All right, we know that in hospice care, family needs are important, but the client's needs are most important. Okay. So let's bring up our week 4 PowerPoint. Okay, and I'm just going to go through my notes as we're going through this to see what we haven't covered. All right, so week 4, special vulnerable populations we covered, or we're covering. the pregnant adolescent, LGBTQ, which we cover pretty extensively, mental illness, and then alcohol, tobacco, and other drugs. So here's a question for you. What challenges do pregnant teens face other than dropping out of school? We know that's a common occurrence. What else about pregnant teens?
Nutrition.
Nutrition. What else?
Financial stability.
Financial stability. Yep.
Housing.
Sexual transmitted diseases,
Say that again.
sexually transmitted diseases,
Yep.
High level of stress.
Mental health.
Yes. Mental health. Violence. Domestic violence. Very common with adolescent teens. Okay, so we know that women, they have several challenges. We already mentioned STIs, drugs, and alcohol are common. Poor nutrition is common. All right, maybe delayed care, delayed prenatal care.
yeah. Mhm.
Why? Why delay prenatal care? Maybe afraid to tell anybody? Peer pressure?
Yeah, keeping it a secret.
Keeping it a secret? Yep. We know there's a direct correlation exists between poverty and poor health outcomes. We talked about that. We talked about the three times more likely to drop out of school. We know that racial and ethnic minority groups have higher rates of teen pregnancy because, why? Increased risk of poverty, increased risk of access to appropriate health care, increased risk of lack of educational opportunities, higher rates of abuse and violence during pregnancy, lack of social support networks, maybe within their family or within the community. We know that we talked about higher rates of STDs. What about a homeless? How do you care for a pregnant adolescent that's homeless? What would you do?
Provide her resources.
Resources, right? I mean, sometimes you don't even know, right? That fear of telling anybody. So not only do pregnant adolescents present high risks, but pregnant homeless adolescents. If you're working with the homeless population, you're likely to be working also with a teen pregnancies as well. What are you going to do? Let's say you're working with a teen adolescent that is involved in domestic violence. What are some things you might want to do? What about safety? Ensuring her safety. Talking about a safety plan. Where can you go? Are there shelters? Where are your important documents that you need? What are important phone numbers that you need? So safety plan is key. Let's say you are the home health nurse and you now, the teen has now delivered. You're the home health nurse and you're doing postpartum visit. What are some issues? What are some issues you would be looking for?
Bounding.
Does the baby have somewhere to sleep?
Bonding.
Looking to see if the baby has
Food.
somewhere to sleep, crib.
Yeah. Does the mother know how to meet the baby's needs? Right? What else, Tamisha?
Well, seeing if the baby has formula or, I mean, any kind of nutrition.
Diapers? We have nutrition? Do we have diapers? The baby's crying? Can
mother
mom meet the
level.
needs? Pardon me?
Postpartum stress level for the mother.
Absolutely. You know, when you go into that home and do that postpartum assessment, or they come into the clinic for postpartum visit, there's lots of things you need to assess. Are they alone? Do they come with a support system? What does that support? And if you're in the home, what does that support system look like? Is the environment calm? Is it chaotic? What's the communication between the members who are involved? Is the father involved? Is he not? Can mom meet the needs of the baby? There's a lot of high risks postpartum that we need to be assessing. Is the mom aware of growth and development? Does she know what milestones need to be met or should be met at certain times? Is there a plan for her to go back into school? What resources as the community nurse can you provide her?
And also educate her on her nutritional needs.
Pardon me?
Educate her on her nutritional needs, find out
Yep.
if she has resources for herself.
Yeah. Yeah, the postpartum adolescent who's just had a baby presents quite a bit of risks. And if you're working with this population, you have to know what the resources are available in the community for this population, whether it be food resources, diaper resources, mental health resources, postpartum follow-up resources. Okay. We covered the LGBTQ population pretty well. The only thing I want to mention, we talked about caring, understanding our own feelings, providing a safe environment. I want to talk about CDC recommendations. Okay, for this particular population, the CDC provides recommendations for screenings, right, for the prevention of STDs with this population. Does anybody know what these 5 screenings are that are recommended annually with this population? Well, it's right here, actually. The CDC.
HIV,
Yeah.
HIV, gonorrhea, herpes, chlamydia, syphilis.
Yep. Yep. Those are the 5 that are recommended annually. However, if certain individuals within this population are higher risk, and there's 2 reasons they would be higher risk. 1, if they have multiple or anonymous sexual partners. And 2, if they're using illicit drugs in conjunction with sex. That makes them higher risk. Therefore, the interval jumps down to 3 to 6 months versus annual. Okay? Any questions about that? Okay, let's talk about mental illness. I think we covered PTSD and we covered anxiety. All right, we talked about anxiety being a normal part. Here's the other mental illnesses that I want you to be aware of. General anxiety disorder. What's general anxiety disorder? What did you get from your readings? Second bullet here. What is it?
Fears and phobias.
Nope, let's talk about general anxiety disorder. What is that? Let's do that first.
Like excessive, like worrying about stuff, worrying about things.
Okay. Persistent, unrealistic, excessive worry about two or more life circumstances for at least 6 months. That's the definition, right? Or longer, 6 months or longer, right? It usually develops slowly, but it's chronic in nature. Okay. The worriness is unusually frequent. Okay, that's your general anxiety disorder. What's a phobia? What's a phobia?
A fear of something.
Okay. Excessive, irrational fear of something, an activity, an object, a situation. All right. It's a fear that can lead to avoidance or extreme anxiety, right? And it interferes with your normal responsibilities and routines. Okay. Next one is OCD. What's OCD? You should have read through this in your mental health chapter in the book. What's OCD?
Obsessive compulsive disorder.
Okay. Okay, what is it? Explain that a little bit further.
Your obsession with one or more thing of being perfect, or it's not up to your standard, and you're constantly checking on its progress or its stability.
Yep. Constantly thinking about it, right? Right? And that constant obsession with thinking about it causes quite a bit of anxiety, right? And then the last one that's not on this is suicidal ideations. If you're working with clients that have suicidal ideations, what do we need to be thinking about? What's important?
We need to ask them, do they have a plan? What are their plans to harm themselves?
Right. We have to assess that. If they have suicidal ideations, we need to be asking those important questions because safety is our primary concern, right? Do you have a plan? Do you have the means to carry out your plan? What is your plan? Have you attempted suicide before? Okay. And then the one medication I wanted you to be familiar with, and it's on the bottom of this slide, is lithium. What do we use lithium to treat commonly?
Bipolar disorder.
Bipolar. And so this is the medication that I want you to know about of what we would do for teaching points. Let's say you're working with a client who is on lithium, you just started taking lithium. What are some important teaching points?
You have to know the lithium levels, what is toxic for that individual.
Correct.
Keep hydrated.
Hydration. Encourage normal salt intake. Report any kind of diarrhea. Report any kind of vomiting, tremors, or lack of consciousness. And hydration.
And do not abruptly stop taking that medication.
Correct. Yeah. Let's talk about alcohol, tobacco, and other drug problems. Okay. So we know that substance abuse contributes to a lot of things. Contributes to teen pregnancies, contributes to STDs, contributes to HIV, contributes to domestic violence, child abuse, motor vehicle accidents, physical fights, crime, homicide, suicide. Right? A client's current health may alter the drug effects from one day to the next if there are existing comorbidities. Right? Some people are genetically predisposed to certain drugs, alcoholism, right? So simply their chemical makeup and consuming drug or alcohol will trigger the disease. Lot of heredity in this, right? People with, I'm just reading from my notes here as well, adding to the discussion, people with underlying mood disorders or other mental illnesses, you know, they may try and self-medicate with psychoactive drugs, right? Then we talk about influence, okay? Influence at all age groups. Influences from peers. Maybe there are physical influences, social, cultural. They all play a part in this, right? Think about all the peer pressure in the schools. When I was in the schools doing school nursing, teaching primary prevention for drugs with the middle and high school kids, we talked about peer pressure. Okay. What about the advertising? Advertising of these drugs, advertising of alcohol, advertising of tobacco, right? They advertise so you're going to feel better, you're going to sleep better, you're going to feel better, you're going to have more energy, right? I think about energy drinks, and that's one of our substances that we talk about. And all your life problems are going to be solved, right? With your energy drinks or smoking cigarettes or your methamphetamines, right? There's a couple of terms that I want you to be familiar with. Okay. Substance abuse. What's substance abuse? These terms should have been in your reading. So I want to go over substance abuse, drug dependence, withdrawal detox, drug addiction, polysubstance abuse, and alcoholism. Do you know what these all are? You're going to get asked about these on the next exam, given scenarios, and ask what is this scenario? Is this scenario somebody going through withdrawal? Is the scenario somebody with drug dependence? Okay, so do you know the differences between these? And if you don't, go back to your reading and identify what the differences are. Okay. What are the difference in drugs that people are taking? Psychoactive drugs and specific effects. What's a depressant? What's a stimulant? Energy drinks. What are the effects of nicotine and tobacco? Vaping, e-cigarettes, alcohol, cocaine, methamphetamines, amphetamines. Okay, these are all the choices. Okay, and I just need you to have an idea of what each one does. What does a depressant do to your central nervous system? What do stimulants do to your central nervous system? How do they affect? If people came into your work area, urgent care, emergency room, how would you assess? Get to the bottom of what, you know, if they've been abusing drugs or other alcohol, tobacco, other drugs, how would you be able to determine? Is this a cocaine overdose? Is this an alcohol overdose? Is this a meth overdose? Okay, so these are the drugs that I want you to be familiar with. And then lastly, what are some common or some community-based activities at substance abuse prevention? This is what I did all the time in the schools, primary prevention. Really important for our younger generation. Are there school activities that students can participate in? After school clubs, sports? Are there assistance programs if we have screened students and we have a group of students who may be at risk, alcohol abuse, tobacco abuse, other drug abuse? Are there assistance programs within the school that can help these students that are at risk? What about parental awareness? Are parents aware? Do they know the signs that their kid might be drinking, their kid might be using drugs, smoking, using vapes? I want to see the education to parents as well. Are there recreational activities that the kids can get involved in? Teaching anti-peer pressure skills, since so much of this is brought on by peer pressure. Okay, and the general health screenings for alcohol, tobacco, and other drug use. That's how we identify, that's how we did our secondary screening, secondary prevention. Screening. How do we screen these kids who are at risk, at least in the middle and high school? That's how we identified our risk kids so that we could work with them to reverse that course. Maybe they had already started drinking, they had already started vaping, started smoking. Okay, so primary prevention, community-based activities is really important with this topic, because so many of our young generation are already involved in all of this, are they not? What are some other things we could do for this particular population? What are some other things we could do for primary prevention?
Educate.
Yep, we just talked about that. Yep, educate. Educate on maybe the long-term health effects of smoking, the long-term health effects of alcohol abuse, long-term effects of drug abuse, short-term effects as well. Alcohol, tobacco, and other drug use in this country is a major, major problem. Look at all the statistics and the numbers of overdoses, fentanyl. And this is something we can't ignore. Right? Very, very big issue. And we only just scratched the surface. Okay. Let's move on to this week. Okay. Where we talk about hospice and palliative care, death and dying, faith and spirituality. What is a faith community nurse? What are some ethical principles we should be following in our work? And who does the American Nurses Association represent, and what do they do? Okay, so let's talk about hospice and palliative care. I think it was who brought up at the very beginning to talk about the difference between hospice and palliative care. Was that Jeanette? Okay, what is the difference? There is a difference. What is the difference? What did you learn in your reading?
Me?
Jeanette, what did you learn in your reading about?
So I learned that where I'm confused at is in hospice you can have palliative care.
Absolutely.
But hospice is keeping you comfortable, and hospice is where they think you will die in under 6 months, but
Correct.
palliative also keeps you comfortable, but you're getting treatment. I don't really understand.
So let me give you a real life example, Jeanette. My daughter-in-law's father has just been through a whole lot of medical stuff. Had his colon removed for cancer, has had infection after infection, had just one thing after the other. Okay, he's got a feeding tube, he's got a colostomy bag, he's got a PICC line, and what was pardon me? And what was supposed to go in for a surgery and come home with a temporary ostomy bag has now turned into a whole bunch of other issues. Okay. So they have ordered, the physician has ordered that he start palliative care. Okay, so palliative care. So that is comfort. That is palliative care is helping with his symptoms, helping with his mental health to get through that. Helping, he's not terminal, right? He's not terminal. So this palliative care is starting to help him cope with all these traumas and help him manage his symptoms, both physiological and emotionally. Right?
Can I ask a
So
question?
oh, go ahead.
So basically, I don't understand what you're saying. I do understand, but I'm trying to make sure. So basically, palliative care is care that you can give during any stage of a disease. Like it don't
Right.
have to be the end of life care. It's any
Correct.
stage.
And
Okay.
that's where there's a lot of
So the requirement is not for them to have to be like expected death in 6 months. You don't need that requirement for palliative care.
No.
Is that what?
Correct.
Okay.
That's exactly what I'm saying. And palliative care can certainly go into hospice care, right? Let's say that
That
same
would depend on the condition and worsening, right? That would
exactly.
okay, okay, I get it.
That's
Thank you.
exactly right. Right. So a lot of people tie palliative care to hospice care. That may and may not be true, right? Although he had cancer, that's been resolved. Cancer is not the issue now. So he doesn't have a terminal disease. So his palliative care right now is to trying to manage all these life changes and symptoms and new issues that he has. Right? Now, take somebody else in that scenario who has been diagnosed with a terminal illness and they have 2, 3, 5 years to live. They may need palliative care up to the point where they become terminal, that's 6 months. Does that make sense? Where then that transfers into hospice care.
So basically, the difference is hospice, you're not treated. Is that
Well,
what
in hospice and palliative care, the goal is to trying to alleviate suffering as much as possible without attempting to cure,
to cure
improve.
it?
Exactly.
So that's the
Exactly.
difference. Like you're trying to cure in
Yeah.
palliative care while making them comfortable, but hospice, there is no cure. So you're just
In
treating them.
palliative care, you're trying to improve their symptoms. You're trying to improve their comfort. You're trying to improve their situation. Right?
So in
Help them with their
hospice-
symptoms. Go ahead.
Sorry. So
No,
in
go ahead.
hospice, you wouldn't get chemo, but in palliative, you would get chemo or you wouldn't get chemo.
You would. You would.
So is that why hospice patients and like assisted living in nursing homes, they can't go to the hospital, like, because it's already like they're gonna
Well, hospice care
expecting them to die. Like if
Yes.
something happened in the nursing home, they can't go to the hospital. All the ones I worked at, they said you can't send them out because they're on hospice.
Right.
Like hospice gotta
In
come to them.
hospice care, you've stopped all treatment.
Right. Okay. All right. That's a better way to put it. In
How's that?
okay. In palliative care, you still have treatment, but also comfort management. In
Correct.
hospice care, you stop.
Oh, okay.
Comfort.
Focus on
That's
the quality of life.
Correct. Exactly.
So you'll still get care with you'll still get curative care with palliative care, but with hospice you won't. So you'll still get you'll go to the ER in the hospital with palliative, but you
Sure.
won't with hospice.
Right. Because hospice, to qualify for hospice, the treatments have to be stopped.
because
You're in the end of the stages of life.
and the treatment has to stop because all the drugs you're getting is going to kill you eventually anyway,
Right.
or like speed up your death.
That's that transition from palliative care to hospice care. Right? Let's see. Aggressive treatments are stopped. This is hospice care. Chemo, dialysis, ventilation, right? The goal when you get to hospice becomes focused on the quality of life rather than the quantity, right? And hospice care can be provided in home, hospice centers, long-term care facilities, right? And palliative care is provided wherever the client is, right? They might be at home, they may be in long-term care facilities, they may be in rehab facilities. Okay. One of the things to understand in both palliative, so here you go. Generally, the patient has a prognosis of no more, this is hospice, no more than 6 months if all treatments were stopped. Okay, as soon as the health team acknowledges that there is no cure, that's when hospice discussions are initiated, right? We're focused on social support, psychological support, and spiritual support. Okay. One of the things to remember about hospice and palliative care is the stages of grief. Okay. Denial, anger, bargaining, depression, acceptance. What we need to understand in both of these care areas, palliative and hospice, is everybody involved. Okay. The client themselves, family members, friends, everybody's in different stages of grief. And you're going to get asked about this on the next exam, given a scenario. So-and-so is doing this. What stage of grief is that? So have an understanding of your stages of grief, because in this care, hospice and palliative care, stages of grief are really important. You don't have to be a hospice nurse or just to observe stages of grief. There's a lot of stages of grief in palliative care too. Does that make sense? I mean, just within my family going through this with my daughter-in-law, every single person is in a different stage of grief. Meaning some are denying it's even going on, right? Some have accepted it, right? So be aware of your stages of grief, okay? One of the things that's also important in hospice and palliative care is trying to avoid making decisions for everybody, you as the nurse, right? That's that autonomy. Okay, they've already lost a lot of control over a lot of things, right? So we want to encourage their involvement to the extent that they can be involved in planning out their care. We don't want to take that away from them too. And that includes the family as well. Okay. The other thing that's important with this kind of care is therapeutic communication. Right? Open-ended questions. How do you feel about things? What do you know about your disease? What do you know about the seriousness of it? What do you think palliative care is? What do you think we should be providing for you? Okay, the openness of the communication is critical as well. Okay. We kind of just went through this. Hospice care and long-term facilities, 6 months if all treatment is stopped. Communication, pain control. Palliative care is providing quality of life, alleviating suffering, improve the levels of suffering they're going through. So there's a good summary right there. Jeanette, Chantal, does that make sense?
Yeah.
Okay. Faith, spirituality, and culture. Okay. A lot of times in this kind of care with hospice, palliative care, we involve spiritual people, spiritual leaders. Okay. Bring in the faith part of the care. All right. We talked about cultural competences and understanding our own culture and biases. Okay, so we need to think about cultural competence when caring for these clients as well, not just your special vulnerable populations that we talked about from week 4. All right, clients that are palliative, in palliative care, hospice care, we also have to consider their cultural beliefs. A lot of cultures have different beliefs of end-of-life practices, right? So we need to be very aware of attitudes, beliefs, practices in certain cultures. Okay. We know that we have to take into consideration time orientation. All right. Some cultures are past oriented. Some cultures are present. Some are focused. All comes with it, positive and negative. You know, if your culture is so focused on the past, you tend to not look at what the needs are for the future. If you're so focused on the future, you tend to not think about what's going on in the here and now and what needs to be done. Okay. Don't treat every patient as you would like to be treated, right? Because cultures may be vastly different. Okay. And how do we attain cultural competence? Here's your answer right there. All right. Cultural competence is attained when we, as nurses, make a conscious attempt to learn about diverse cultures, people of diverse cultures, and try and look at the world through their eyes. That's true cultural competence. Okay. Part of how we incorporate the spiritual side of care is through spiritual leaders, faith community nurses. And believe it or not, there are faith community nurses. I have a couple of girlfriends back in Denver who have been faith community nurses within a certain congregation for years. Okay, these are whether your congregation is a mosque, whether it's a temple, whether it's a church, whatever your religion is. Okay, a lot of these congregations have faith community nurses. All right, they're usually congregation based, parish based, and they take care of the needs of what the congregation needs. Okay, maybe they need hospice care, maybe they need visits to new moms, maybe they need support groups, grief support groups if they've lost a loved one, maybe they need mental health group sessions. It depends what the congregation needs, but I just want you to know that faith community nurses play an important role in the health of communities if they do have one at their particular place of worship. And the whole purpose of faith community nurses is incorporating the spirituality into their practice. All right, focusing on the holistic mind, body, spirit. Does anybody practice at a place of worship that has a faith community nurse? Nobody? Okay. It's another slide on faith community nursing that you can read through. Ethics. Let's talk about ethics real quick because we're almost done here. Okay. What are ethics? We live by ethics every day. In our
Codes and
work
rules
lives.
to live by.
Pardon me?
Codes and rules to live by.
Yeah.
What you believe is right and wrong.
Exactly. We make ethical decisions all the time, every day, right? Our decision making, whether it's for our family, our kids, our work, school. Okay, it's what you believe to be correct. And there's a couple of ethical principles I want you to know about. One is called beneficence. And this was in your reading. And that requires the nurse to do good. We are, under our nursing code of ethics, should be always practicing beneficence. It's a fancy word, but what it means is we do good. Okay, we do the most good possible within the circumstances we are in. Right? We wouldn't go into take care of a patient and not wanting to be doing good. Right? The other that goes along with beneficence is called non-malfeasance. And I'm sure you read about this if you did your reading. That means do no harm. So as nurses, we are guided by these two principles, beneficence, non-malfeasance. So example of non-malfeasance, let's say you're cathing a patient and you contaminate the sterile field. What do? Do you go get a new kit or you keep going?
Get a new kit.
Hey, go get a new kit. That's a simple example of non-malfeasance. Do no harm. Okay. Another ethical principle that we follow within our profession, and you should in life, is autonomy. Right? Giving people the opportunity to participate, letting them have their voice. Whether it's your kids, whether it's your clients, because remember, part of ethics is also advocacy. We're advocates, right? We're advocates for our clients. We want them to make sure they have all their questions answered about upcoming surgery. They know what kind of surgery they're having. They know what kind of resources they need. Okay, advocates. Do they know all the discharge instructions when they go home? Okay, do they have all the necessary insurance information that they need? Okay, advocacy. Advocacy is, does the client have everything they need to make informed decisions? We are having the client's best need, we have the client's best needs in the forefront. Okay. Okay. Just American Nurses Association. We are all part of the American Nurses Association, but you need to know what they are because you're going to get asked about it. Okay. So they represent all the nurses in the United States. Okay. So of course, if they represent all the nurses, they have to be general. What they have to do is have general guidelines, right? Because we have so many different kinds of nurses, right? They're not OB focused or peds focused or geri focused. Okay. They're general standards and guidelines for nursing practice as a whole. Okay. They apply to the whole nation. Okay. So what I want you to understand is they're not specific guidelines focused on a certain profession of nursing. They are general guidelines, standards guidelines that cover all of the nursing profession. Okay. So I have a couple of ethical issues to talk about. One is documentation. Documentation falls within ethics. We know what we document is objective, correct? What we see, what we hear, what we smell, that's what we document. Factual information, right? We cannot be documenting subjective. I think this patient is angry this morning. What are some other examples of subjective comments?
They taught us that subjective mean what the patient tell you, like when they telling you their symptoms. They didn't say it means like if the patient seems irritable. They said if the patient says, I feel angry, or I feel sad, or my stomach hurts, that's subjective information. And they said that you should document subjective information. Depending what it is, you should document the client's exact statement though.
Yeah.
Not in your words, the exact statement.
Correct. That's objective. The patient states that to you. Subjective would be, oh, the patient seems angry this morning. The patient seems tired this morning. Well, did the patient tell you they're tired, or are you just making that assumption, or that's your observation? Does that make sense?
Confused now. No, it doesn't. It just confusing because that's not what I had, and that's not what I was taught of subjective versus objective. I was taught that objective is, like you said, vital signs, stuff that you can see, blood results, lab tests. Subjective information is a client telling you their symptoms, like the client's words itself is subjective. But you saying, what did you just said something in the opposite of what I said?
Okay.
But I'm under the impression that subjective information, who calling my name?
Darlene.
Oh, okay. Hi, yes.
Subjective is the patient opinion. But when you're saying do not we put your opinion as a nurse, how you see, how you
But
feel.
no, but she just told us that she just said that if the patient says my stomach hurts, she said that's objective. She said that's not subjective.
If the patient says my stomach hurts, that's what you would want to document. Patient states that.
And that's still
you wouldn't,
because objective is only things that we can measure. That's what I was taught. That's what I'm saying. I don't want to be confusing your class being based off of what I was taught. I was taught that subjective is what you can measure, listening to lung sounds, bowel sounds, lab results, blood tests, everything of that nature that you can put on paper, that you can go run a lab or run a test, a COVID test. All of that is objective information, vital signs, blood pressure, heart rate, objective. But if the
Objective,
patient says
correct.
my heart is racing, if the patient says my heart is racing, they told us that that is subjective because that's what the patient is telling you. You can't see that their heart is racing. Like you might see them panicking or something, but you can't see that their heart is racing until you put on that pulse ox,
So
which would be objective then.
So objective would, so objective would be that something that you're hearing, like the patient is stating to you, my heart's racing. That
would be
is
objective.
Objective.
No, she's got it backwards.
I'm
so.
confused. So what's subjective then? If that's objective, what is subjective?
Subjective is your opinions.
I'm a little confused.
I'm sorry. we
Subjective
gotta-
is your opinions. I think the patient is angry this morning. I think the patient looks tired this morning. Now, if the patient
So
states,
basically, what you're saying to me is that if I was a patient of yours and I said my heart is racing, but then you put on a pulse ox and see that my heartbeat is 120 beats per minute. My thing is,
I would be documenting both of those, heart rate,
so those
120,
are both
patient states.
objective, is what you're saying? So what I'm seeing is the heart rate and the patient saying that their heart is racing. Those are both objective information. Because
Objective.
they don't fall in the same category in my eyes, because that's one thing
Okay.
that patient feels, and this is what we're seeing. That's what we were all taught. That's why we're all being confused based on what you're saying. So now I'm going forward, this is going to confuse us.
Okay, well, I have no intention of confusing you.
I know you don't. I'm just trying to get you to understand that this is what we all were taught.
Mhm.
From the
So-
term 3 to now, this is what we all were taught.
So let me read you my notes. Factual documentation contains descriptive, objective information about what the nurse sees, hears, feels, or smells.
Right, beast meaning
Okay.
if they
The use
see
of
lab results are low, if they hear wheezes in the lung sounds, if they hear bowel sounds are not there and stuff like that, I feel like that's what they're saying. I don't believe. All right, I'm gonna just shut up. Never mind.
the use of inferences without supporting factual data is not acceptable because it can be misunderstood. The use of vague terms such as seems like, appears to, right, is not acceptable because these words are really stating your opinion.
I understand that.
Okay.
I understand that part.
Okay.
I
what
just don't understand.
is this? I don't. Who's speaking? Sienna?
It's Chantel.
Oh, Chantel.
Again. Yeah,
Okay.
it's me again.
Why don't you stay on after, and we can talk about this because we're already a bit past the time without taking a break.
But the whole class is confused. It's not just me. The people that I learned this with is confused as well.
Yeah, because that don't make
I don't
sense.
feel
That's how
comfortable
we were
moving
all
forward
taught.
if we're not understanding what you're. I don't feel comfortable moving forward talking about this
Okay.
in different aspects if we're not understanding the basics.
Maybe I'm not. Maybe I'm not
Never mind.
explaining it.
No,
Maybe-
you're just telling us. You're explaining it. I understand what you're trying to explain, but what you're telling us is the complete opposite of what we learned. So now we're confused because we were taught that on tests. That's what we went off of, and that was right. But now you're saying the complete opposite. Is it only for community, or is it just like I don't understand?
I'm just.
If you Google it, it's
I'm
gonna
convi-
say subjective.
But
Even if you Google it,
Can
it's
I
still
say-
gonna say
can-
what
Go ahead.
subjective
No, let her
is.
talk. Go ahead, Kayla.
No. Go ahead.
I was maybe this is what it is. Okay, so how you would write a note, the first thing that you would write is subjective, and it would be the patient states her chest hurts.
Exactly, and that's
Oh,
subjective.
All right, so yes, so it's subjective.
Subjective. Exactly.
Yes, and then the next thing you would write was, I took vital signs, and her vital signs were 100 over.
You will
know,
document the vital signs. Yeah,
Yes,
exactly.
so
That's
you
subjective
document
versus
The
objective.
first thing you document would be like what the patient stated, but
But
what
you're
I
not
think what
understanding what I'm
Professor
saying.
Marvel,
My issue is that she said that the subjective that you just said is subjective, which is what the patient
I'm
states.
talking about
she's
subjective.
saying said what she's saying.
Or
All right, I'm all right, so I think what Professor Marvel is saying is you shouldn't write your opinion. Like
That's
you
what I'm trying
shouldn't.
to
I
say.
understand that. Y'all not understanding what I'm saying. Just listen. What I'm saying is I understand what you're saying. We shouldn't write our own opinion in our own words. We all know that. But you're saying that a patient, Chanel, be quiet. You're saying that a patient stating that their stomach hurts is objective information. We learned that anything a patient states is subjective information because that's what they're telling you.
Okay,
And
let me
objective is
let me
listening.
clarify. What I mean by subjective is stating your opinion.
Okay.
Does that help?
I'm gonna
Does
just
that
let it
help?
go. I'm gonna ask
Hope
Mr.
that's
Rankin.
not confusing.
I go to him for everything.
What
I'm just ask Mr. Rankin.
what I'm trying to say, I guess what I'm trying to say about ethical documentation is it needs to be factual, right? It needs to be vital signs. It needs to be something objective. It needs to be factual. What I'm saying about documentation is that you can't be stating your opinions. It has to be based on factual information. Does that help?
It does. I have one more question based off what you just said. So if it's like I said before, if a patient states my stomach hurts and you put that in documentation, that's not factual. I mean, is the pain is whatever the patient
That's
says,
factual.
but like
That's factual.
but you can't see that. You can't see that. You can't see that
But
on
if a
on
patient states that to you,
so that's objective.
you
is
can't
what
be
you're saying.
saying it looks like, it appears like the patient's stomach
Right.
is hurting.
It's subjective, but it's factual because whatever the
Correct.
patient says.
I understand it's
like-
factual.
Like if
Pain
they're
is whatever
saying,
the patient says,
all right,
but
all right,
all
we
the
allowed
things-
to log off.
Okay,
It's
hang on a
subjective.
second. Hang on, everybody, hang on. I want to respect
right.
everybody's time here. Okay, we're 10 minutes over since we didn't take a break. So everybody just hang tight. If anybody wants to stay on and continue this discussion after class, I'm more than happy to. I think I'm maybe reading too much into this.
Wait, what time is class over? Is it at 2:40?
Class is over at 2:40, but since we don't take a break, we should be finishing 10 minutes early. So that would be 10 minutes ago. So how about this? If anybody wants to stay on and
Okay.
continue this discussion, we can. For all of those that don't want to stay on, you're free to go. And it was good to see you, and I hope you have a good rest of the week. How's that?
So when is class is over now?
Class is over.
Have a good day, Ms. Morar.
Thank you.
Okay. So we're just staying on to continue the conversation.